County. Also on the call tonight is the person you actually want to hear from, Jennifer Cornell, our Director of Long-Term Care. We're going to get into her update in just a moment here. But quickly, I just wanted to give a rundown of our meeting format. I expect most of you have been on one of these calls in the past, but it will start out with an update from Jen about some of the recent changes in long-term care in Ontario and in our homes. Following that, we are going to open it up to a Q&A session, which will last until we run out of questions or 8 o'clock. We will get to as many of them as we can. If you think of anything after the call or you're just not comfortable asking your questions in the Q&A feature here, you can always email communications@grey.ca and we will get back to you as soon as we can. I do as well just want to remind everyone that this video, it discusses matters related to residents of Grey County long-term care homes operated during the COVID-19 pandemic. You can certainly share the link to this video once it's out to others in the Grey County community. And if you have a family member in a long-term care home that isn't operated by Grey County, please contact that home if you have any specific questions or concerns. So with that, Jen, I will pass it over to you if you're ready to go.
Great, thanks, Rob. All right, good evening, everyone. Just gonna pull my notes up here. Rob did, thanks for that introduction. As Rob said, I'm Jennifer, Director of Long-Term Care for our 3 homes, Grey Gables, Lee Manor, and Rockwood Terrace. We met last virtually on July 23rd and have provided some newsletters and updates each week since then. We have received some further directive updates from the province, the Ministry of Long-Term Care and Public Health. Our infection control, staffing, and PPE strategies continue to be in place in the homes. And as of today, there continues to be no positive cases of COVID-19 in any of our 3 homes. The purpose of our call tonight is to provide an update, particularly around visiting. I think that's the biggest update. So I have a little bit of information about our staff surveillance testing. There's been updates to Directive 3, specifically around short-term and temporary absences, updated visiting in long-term care, the Designated Care Partners Program, and as Rob said, answer any questions. So the situation in long-term care continues to be stable in Grey Bruce and also within the Southwest region. We are all working through or closely watching the return to school. And we must keep in mind that there continues to be community spread in our area very minimally, but in Ontario, there does continue to be spread of the virus, and we must remain vigilant in our strategies to prevent the infection and prevent infection coming into the homes. These strategies are our first line of defense in stopping the spread. So I'll give you just a quick overview of the strategies that continue to be in place. Active screening for every person who comes in and out of the building. This includes every team member, every service provider, every visitor. The active screening includes documenting name, contact information, taking temperature, answering specific screening questions, as well as on-the-spot education on donning and doffing, putting on and taking off of our PPE. As I mentioned, this is a very important step in the protection of our residents, staff, and visitors. Staff continue to be working in one facility. We're minimizing the movement of staff from one home area to another home area within the home. All staff and visitors in the home are wearing surgical masks at all times. All new residents moving in are tested for COVID-19 and are isolated for 14 days and also tested at the end of the 14 days. The leadership teams continue to provide support and leadership 7 days a week. Plans are in place in all 3 homes to quickly isolate residents if needed. Plans are in place to quickly move into full outbreak protocol if needed, and we continuously monitor PPE supply and report inventory to the province weekly. So staff interval testing, there's been an update provided by the province regarding the surveillance and detective testing for all staff. This testing is another tool in our toolbox to assist us in our monitoring and prevention of the virus coming into the home. So a July 16th memo from the Ministry of Long-Term Care stated that staff surveillance testing will continue until further notice. And so the homes continue to offer a number of opportunities to have testing done twice per month. Reintroduction of services and programs. In late July, we began reintroducing a variety of services and programs in each home. And each home is at a slightly different stage depending on their unique circumstances. So small group activities have been happening and continue to happen. And they include programs like bingo, cocktails in the garden, crafts, gardening. Music is happening weekly with music in the garden, outdoor concerts, there's theme days. There's been drive-through car shows. Rockwood Terrace is actively recruiting a hairdresser. Lee Manor has a hairdresser ready to start next week, and Grey Gables hairdresser is back on site providing service. And I know this was a well-wished for service to get back into place. OT, occupational therapy and physiotherapy are continuing in the home. In some homes, physio is virtual, but the PTA, so the physiotherapy assistants, remain hands-on. Foot care is being offered and being provided by staff in our home, in each of the homes. Rockwood is continuing with their foot care by staff. Lee Manor is in the process of bringing back in their foot care providers from before, and I need to touch base on my notes. I somehow left Grey Gables off my list, so apologies for that. I'll follow up on that. So directive number 3 from the Provincial Medical Officer of Health remains in place. Its last update was June 10th, and then we received an update on August 28th to allow short-term absences and temporary absences. So I am going to share my screen to share a chart. Let's see. So, Rob, can you confirm that you can see the chart?
Yes, I can.
Okay, so anyone that called in, apologies, you won't be able to see this, but we will share it out with our email follow-up. So this is a chart that was provided by the Ministry of Long-Term Care, and it just goes over the 2 different types of absences that are now allowed under Directive 3. So so short stay absences are for healthcare related, social or other reasons that a resident may leave the home's property for a temporary absence. So that could be an appointment, it could be a medical appointment, it could be a social reason. It does not include overnight stay, with the exception of a single night emergency room visit. So outpatient medical visits are considered a short stay absence, and emergency room visits that take place over a single night are also considered a short stay absence. Residents must be provided with a medical mask to be worn at all times when outside of the home, as long as they can tolerate it. And we are providing some coaching and education around the public health measures. Upon return to the home, residents must be actively screened, but are not required to be tested or self-isolate. And I have a few more specific points to share about this in a minute. I'm going to get to temporary absences. So temporary absences are for personal reasons for 1 or more nights. The home must review and approve all temporary absences based on a case-by-case risk assessment, considering but not limited to the following. So are we able to support self-isolation for the resident for 14 days when they return to the home? What's happening in the community with regards to disease transmission? So are the numbers high in the community or are the numbers very low? What is the risk associated with the planned activities? So is it a visit to the farm with a limited number of people and an overnight? Or is it a concert with 10,000 people? The residents' ability to comply with the local and provincial policies, so universal masking, physical distancing. If the home denies a temporary absence request, we must communicate this to the resident or their substitute decision maker in writing, including the reason for the decision to deny it. Upon return to the home, the resident will be required to self-isolate for 14 days. So as I said, we'll share this chart out. I have another chart that I'm going to share in a minute. I'm going to stop sharing my screen. pull up.
Jen, we do just have a relevant question here, if I could just
Okay.
interrupt. So do short stay absences require advance notice, 24 hours notice? Is there anything about that in there?
Okay, yes. So for a temporary leave of absence, so a social overnight where that needs to be considered on a case-by-case basis, we're asking people to contact a member of the leadership team. So the executive director, director of care would be a good place to start to talk about what that overnight request is and how would the isolating happen when they come back home and those types of things. So we are asking for some notice for that. We need to consider all of the circumstances. For a short-term absence, so that might be going for a drive, going through for ice cream, going to a picnic, something like that. We are asking that there be some notice. We appreciate that sometimes that isn't as easily done as others, but we are asking to contact the home ahead of time, speak to the home area's nurse, so the team lead nurse or the charge nurse, depending on the language in the home. Talk to the nurse. The nurse is going to ask you some questions about where you're going, what you're doing. That's required by the ministry directives. The nurse will explain the recommended public health advice. So reminder about wearing the mask, doing hand hygiene, physical distancing is the other really important piece. The resident will be provided with a surgical mask, and we also ask the visitor that's supporting the resident for this absence to also wear a mask during their time away. You will be asked when you get there to sign the resident out of the home in the sign out book. And the piece that is, I know I've had some feedback that I appreciate is a little bit frustrating, is that we're asking for this social absence, this short-term absence, not to happen on the home's property. So the ministry has been really clear that visits on the home's property must be treated as outdoor visits and must follow the rules of Directive Number 3 for outdoor visits, which are active screening, wearing a mask, and being seated 2 meters apart. So I don't know if that generated some more questions. It's quite possible that that did.
Yeah, so there are quite a few, well, there's a few coming in on these. Would you rather just take them now, Jen, or wait till the end? It's your preference.
Well, I only have a few more things to go through, and there is a chart that might clarify some of this, and then we can go back to the questions. So it's clear as mud, I know, so it's good for us to work through it. So if everyone can just bear with me, I'll just give the rest of the update. So on July 24th, each home set up designated indoor visiting areas, and outdoor visits no longer required a COVID negative test. I wanted to just give a thanks to everybody that's been participating in these calls, because your feedback from our virtual family call on July 23rd was really helpful. And it allowed us to consult with public health in order to offer the opportunity to hug your loved one for 30 seconds or less at the beginning and end of your indoor visit. So that was something that I was able to say, the feedback is really clear. Family members really want to have some close contact at the beginning or end of their visit. And is there no way we can do that? And so it was really helpful to have that feedback. We also, at that time, updated our policy to accommodate school-age children as the second visitor when accompanied by an adult. So on September 2nd, the new visiting guidelines were released, which included a caregiver definition that's very similar to our designated care partner, and increased the designated care partner to 2 caregivers visiting at one time. Our homes are well prepared and have been actively working on the next steps to expansion of our designated care partner pilot. So I'm going to share my screen again to go over the different types of visiting that are now outlined in the ministry guidelines. And this will help a little bit, I think, and then we'll just kind of work our way through it. I just need to pull that screen up. Share my screen. Technology, isn't it amazing? Okay. So if anyone had asked me a year ago the definitions of visitors, I would never have been able to come up with as many as we have. But here we are, and this is what happens in a pandemic when we need to come up with a safe, balanced way of having our residents and families reunited. So there are 4 different types of visitors. So there are general, and this is as determined by the Ministry of Long-Term Care. So there are general visitors. A general visitor is a person who is not an essential visitor and is visiting to provide non-essential services. They may or may not be hired by the home or the resident, and they are there for social reasons that the resident or substitute decision maker assesses as different from direct care, including care related to, okay, so a general visitor is someone who is not providing that kind of direct care support. They're visiting at a window visit, at an outdoor visit. They don't require a COVID test. And I have another chart that I'll share with everyone to outline all of the different requirements. A support worker, as per the ministry, is a type of an essential visitor who's visiting to perform essential support services for the home or for the resident at the home. This includes physicians, maintenance workers coming in to do critical maintenance work, people delivering food, provided they're not the staff of the home. It might be the, oh no, phlebotomist is in the next one. So those are support workers. Essential visitors. Our policy must specify that an essential visitor is defined as a person performing essential support services. So that might be also delivery, an inspector, healthcare services like lab, phlebotomy, or a person visiting a very ill or palliative resident. And that's where we've used essential visiting guidelines to support residents and family members being together in the case of end of life, in the case of a resident who may be having some responsive behaviors, and that support of that family member helps to minimize that. So there's been a lot of different areas that we've used essential visitors. And then a caregiver, which is the words of the province, is the same as our designated care partner. So a designated care partner is a type of an essential visitor who's designated by the resident or their substitute decision maker if the resident can't designate. And they're visiting to provide direct care to the resident to support things like mealtime, mobility, cognitive stimulation, communication, meaningful connection, relational continuity, and assistance in decision-making. Examples of caregivers or designated care partners include family members who provide meaningful connection. It might be a privately hired caregiver, a paid companion or translator, and it can be a family member, friend, neighbor. Okay, the next chart is a way to help us keep track of who needs what requirements, what's required in order to be each different type of visitor. So the types of visits go across the top, and what are the requirements go down the side. So a virtual visit is scheduled through our online booking tool. There's no restrictions for the number of visitors in a virtual visit. No screening is required, no PPE is required. It is permitted during an outbreak, and there's no additional education required. Window visits are also scheduled through our online booking. There are no restrictions to the number of visitors. Screening is not required. If you are there alone, you don't need to wear a mask, but if you're with a group, public health would say that you should wear a mask because you won't have the physical distance. So physical distancing is required in a window visit. So we did have a couple of challenges with people getting really close to the screens. So we needed to move people back a little bit. You do not need a negative COVID test in the last 14 days, and they are permitted during an outbreak. Outdoor visits are also booked through our online booking tool. 2 visitors can be there at a time. you do require screening. You are required to wear a mask. You are required to physical distance. You are not required to have a negative COVID test. They are not permitted during an outbreak, as far as we know at this point, and there is an education requirement. And outdoor visits are susceptible to weather. So if the weather is really terrible, they could be canceled. Indoor visits are booked through our team, our online booking tool. 2 visitors at a time are permitted. You do need to be screened, wear a mask, do physical distancing, although this is where public health supported us in having some language to allow a 30-second or less hug at the beginning and the end of the visit. And if you give somebody a 30-second hug, and 30 seconds it's not long enough if you haven't seen someone for a number of months, but I was hugging my kids and my youngest said, "Are you counting?" And I was. So you get to 15 and that's a pretty long hug. Negative COVID test in the last 14 days, you do need to have that in order to do an indoor visit. They are not permitted during an outbreak, and there is education required, and it's provided at the screening table. An essential visitor is coordinated through our leadership team based on acute changes in condition, critical illness, or palliative care. 2 visitors are permitted at a time if the resident is not self-isolating or symptomatic. If the resident is self-isolating or symptomatic of COVID, then it's reduced to 1 visitor. You do need to be screened. You do need to wear a mask, and depending on the circumstances, you may also need to wear a gown. Physical distancing is not required, but must be maintained with other residents or other members of the care team. If there is time, then we appreciate you getting a COVID-19 test in the last 14 days. If time does not permit that, then you are not required to have a negative test. 1 visitor for essential reasons are permitted during an outbreak. And if time allows, there is an education component. So the designated care partner, which is really the expanded visiting that has just come out in the new guidelines, is going to be coordinated through our leadership team. It's actually going to be coordinated through our commitment pledge that is part of the education package. And so we'll talk about that in a minute. Sherry sent me an updated chart, and I am sharing the wrong one. Maximum number of visitors is 2. You are required to screen. You are required to wear a mask. You are not required to physical distance from the resident during the visit, but you are asked to maintain distance from other residents. So if there's a shared room and other care team members, you are required to have a negative COVID test in the last 14 days. 1 DCP will continue to be allowed to visit at a time during an outbreak. So this is what's really new and was always the goal of our pilot program, was to expand it to everyone and be able to have residents have identified some support for them in the case of an outbreak where we are not required to limit and restrict all visiting. So the guidelines are clear that in an outbreak, 1 DCP will continue to be able to visit at a time, and education is required. So that's a lot of information, and we will share these charts. I'm going to keep them handy as we go through, and I saw lots of questions popping up. So I'll just finish up the update and then we'll get to the questions. So we received these updated guidelines late Wednesday of last week. The teams in the home have been meeting with residents and/or contacting their power of attorney to identify their 2 designated care partners. They are about 70% through the list in talking to residents, and the goal is to have 2 DCPs identified and contacted for each resident by the end of the week. These calls take some time, and we are happy to take the time to help people consider all of the options and responsibilities that come along with being a designated care partner. There is flexibility in the decision making. So for example, Some people are choosing to have only one designated care partner. Some people are opting to wait a few weeks to see how things go with kids getting back to school. And some people are suggesting to their resident that they ask another family member because they have an underlying health condition or they're a frontline worker at a grocery store, for example. So there's people have a lot of questions and there's a lot of things to consider. And we've seen that with the pilot. So the pilot started at the beginning of August. It's been going very well, and the feedback from the participants in the pilot have been really helpful in us determining what are some of the questions that people are going to have as we expand the program. So once the DCPs are finalized, we will send out an email with all of the information that you need in order to do your education, complete the commitment form, and we'll also include information about the COVID testing centers. We sent out a survey asking about visiting, and I want to thank everyone that took the time to complete the survey. We had 119 respondents, which I think is a really good response. 62% of the respondents are interested in being a DCP. 42% are interested in being a DCP right away, and 67% of the people are thinking of waiting to do their indoor visit when it has less restrictions. So this feedback is consistent with what we've been hearing from families throughout the pandemic. For some people, virtual visits, window visits, outdoor visits are working well. For others, in-person, indoor, and now bedside visits will be best. So we'll continue to offer the variety of visiting options in order to best meet the needs of the residents and their families. So there are virtual visits continuing, window visits, outdoor visits, indoor visits, essential, and now designated care partner visits. We are looking at what are we going to do in the winter because window visits will be okay for short periods of time. Outdoor visits won't be sustainable as the weather changes. So we're looking at what those options might be. Last couple of things and then we'll get to questions. So our staffing levels remain stable. However, a number of our students that worked throughout the summer have headed back to school. So we are actively recruiting in a number of areas across the 3 homes. We're recruiting registered nurses, PSWs, food service workers, and emergency support workers that support our screening roles and to support the nursing teams when we are shorthanded. Our team members are our #1 asset, and our goal is to be an employer of choice, offering a great work experience. I can't thank our staff enough for all they have done and continue to do to color it for our residents. The teams in the homes continue to keep the residents up to date as well. It's a priority is to keep our residents up to date with the new directives and visiting changes and all of that information. And they're using the Ontario Association of Residents Council templates to help support that. With an increase of people coming and going from the home, our in-house strategies that I talked about at the beginning are as important now as they were in March. So our universal masking, our hand hygiene, our changing of uniforms, active screening, physical distancing for residents at meals and activities, quick plans to isolate and test. These are the initiatives that will help us manage if we encounter a COVID-19 case. So we must remain vigilant in our efforts. They've got us this far, and I know that we can do this throughout the fall. So clear as mud, lots of information. Happy to get to questions and see if we can clear up some of the questions around visiting, and we'll just work our way through it because even the teams, we did this too. I also just want to share that the links that went out with the invite for this call are the exact documents that we received. So I thought it was really important that each of you have a chance to read the guidelines, the exact guidelines that we received. And we just worked our way through them and have done our best to make sure we haven't missed something.
And kudos and thank you to you, Jennifer, and your staff for making up those charts, because as we all just heard, there is quite a bit to process through here, and I think those are going to be very helpful. So we'll make sure that those are front and center when we do send out the follow-up to this call tonight. So we have a few questions have come in here as well. And if you do have more as we're continuing here, don't be shy about putting them in the Q&A button and we will get to as many as we can. So our first one is regarding a power of attorney. How much authority does a power of attorney have to determine who can take a loved one out during the day?
Okay, well, it really depends on the circumstance of the resident. If the resident is making their own decisions, then it's up to the resident where they go and who they go with. If the resident isn't able to make those decisions, then it does fall to the substitute decision maker outlined by the power of attorney as to who and where, who the resident goes with and where they're going. They become the decision maker for the resident if the resident can't make their decisions.
Are visitors able to have meals with our loved ones? And I'm not certain if that's in the room or out of the home, so maybe you could answer both.
Right. So for a short-term absence, if the resident is going out with their loved one and they're going to, let's say, to drive through the Dairy Queen and get an ice cream, then each resident, the resident and the visitor will take their mask off and eat their ice cream. You should do hand hygiene first, eat your ice cream, do hand hygiene, put your mask back on, do hand hygiene. You can't do enough hand hygiene. But in the home, the designated care partner can support the resident with their meal, but at this point, they can't eat a meal while the resident's eating a meal. If it's, I think that I think that this is something that you should also discuss with the director of care around what your DCP visit is about. There could be a way physically distanced, so you're sitting at tables 6 feet apart. This is something that we need to follow up with public health. I'd like to do a quick email to our representative and our support person at public health about this question. So why don't you connect with either Rob or I after and we'll get more details, or connect with the home.
Right. For a short-term visit, may a family member take the resident to their home?
Yes. Yeah, so the nurse is going to ask lots of questions about where you're going and what you're doing, and that's because they need to do a risk assessment. So a concert with 10,000 people is much more risky in terms of infectious diseases than the dining room in your house at home. And so they'll just be asking those questions.
Thank you. So Dale is a designated care partner. Can she take her mom out for a walk and have that occur off the property? Would that qualify as a short stay absence or just a resident going for a walk?
I know anything that was simple is no longer simple. So if you leave the property, I would say right now, under the information we have, that would be a short stay absence. As for supporting your DC, as a DCP, supporting your resident to do a walk, that just needs to be coordinated with the team in the home. And I know that there are some residents who taking a stroll around the garden is really helpful in minimizing their responsive behaviors and maybe some agitation that comes with dementia. And that just needs to be coordinated with the team at the home so that we don't have too many DCPs and residents running into each other. We have to try to have measures in place to keep people distanced.
Okay, so I'm going to dig into that one a little bit, Jen. So if it's walking around on the grounds, that is the DCP, the designated care partner, that can do that. And that does tie into a question from Rachel, or just looking for more information about why the visits for not the designated care partners, but the visits can't happen on the grounds for the short stay absence. At Lee Manor, there's hills surrounding the residence, which do make it difficult for the residents to get around, especially in wheelchairs that aren't motorized. And that could be a disadvantage for those who can't easily transport their loved ones.
Yeah, I appreciate that challenge, and the teams, we talked about this a little bit, well, quite a lot last week in preparing for the call and the communication out to families and residents. So I participated in an information session put on by the Ministry of Long-Term Care, and this question was asked specifically. And the response was, if a visit is happening on the grounds, it's considered an outdoor visit and must comply with directive number 3. And what that means is it must be physically distanced, it must be pre-scheduled, it must include masking and hand hygiene. So the ministry did appreciate the challenges that came with that, because so you're on the lawn, you're on the sidewalk, it doesn't seem like a big difference. And so they appreciated the challenge. They have said that there will be updates continuously with the visiting guidelines as the communities move through the phases of reopening. So I'm hopeful that we will be able that there'll be some changes to that. For now, we have to comply with directive number 3. Also, hopefully, by having designated care partners in the home, it will ease some of the pressure to take people out for a short-term absence, because there's opportunity for people to come into the home and do some visits. So the timing was challenging with absences coming before the updated guidelines. So people were feeling a lot of pressure to take someone out of the home for an absence that maybe they wouldn't have done that over the last few years. But because you couldn't get into the home, there was this pressure that's the only way you could have a visit. So hopefully as we roll out the DCP program and people are getting into the home at the bedside doing visits, that will ease some of that pressure.
Thanks. So we have a couple questions about COVID test requirements here, and I'm not sure if this was on the chart. Is a COVID test required for an individual who might take a resident out for a social visit? So they'll be getting in the car. Okay. That was in here a couple of times. So that is not required.
That's right. And that's why we are taking very seriously our requirement to do education. So that's why the nurse, the clinical leader, that nurse is going to be saying, so where are you headed? What are you doing? Please don't forget to leave your mask on. Keep your mask on. Here, do your hand hygiene, and so on and so forth.
All right, thanks. Just sticking within the chat window here. So to elaborate on movement in the homes, as a designated care partner, I understood we must go directly to the room and stay there, and we cannot walk the corridors with our loved one. Is this correct? This would maybe go back to walking the gardens.
Yeah. So again, the ministry has said it's up to each home to have their policies and their procedures and educate and work with family members and caregivers. So that's the DCPs. So we are wanting people to communicate with the teams in the homes about what is it that you will be doing as a DCP. So think of it as before COVID, you were coming into the home 3 times a week. There were certain things that you did when you were there. Are those going to be the same types of things that you're going to do? Are you still planning on coming in 3 times a week? Some people came in once a week. Some people came in every day. And so we are expecting, and based on the survey results, we're expecting that will be, it'll vary like that from resident to resident. And that will help us to not have to have too many rules, but still be able to keep everyone safe in the home. So remember, we're going from very restricted visiting, very limited number of people coming and going. And now we're really expanding that. And so every interaction of people coming and going does bring with it some risk of transmission of not just COVID-19, but other infectious things like influenza, stomach flus. And so we are expecting that as part of the DCP program, there's a form, and some of the folks on the pilot will have seen this. It's a commitment form. It says what you're going to do as a DCP and what the rules are that you're going to follow. It says what the home is going to follow and what their responsibility is to keep you safe and to communicate. And there's a number of different pieces to it. And there's a section where you will write how often are you anticipating you'll be visiting and what types of things might you be doing. So you might have always come in and helped with meals, or maybe you came in and did a social visit. You made sure your hearing aid batteries were changed, and maybe you're not even sure. You did lots of things, but you'll need to kind of do some reflection and think about what that looks like. We're trying not to have too many rules, but still maintain safety. So in getting back to the specific question, if you would like to go for a walk, then you need to talk to the team. So either the clinical team, so the nurses, or in some of the homes, the program team is supporting the DCPs and the coordination of what they're doing, what you're doing. So you just need to talk to the team and sort out what the timing looks like and how many other people are in the home. If you're able to visit in the room and support your loved one and have a good visit without going out of the room, that would be ideal, but we appreciate that's not always the case.
So this participant on the call has had a hard time getting through to someone to set up a short-term absence. Now, I know our staff are just adjusting to these new processes as well. Is there someone specific that family members should be contacting at the home to set these visits up and just keep things moving along?
Sure. The best bet would be to call the number to reach the nurse of the home area that your loved one lives on. And then if that doesn't work, you can always press 0 and someone will answer and help you find the right person to talk to.
So Nancy asks, at what point will I be able to visit my parent in her room since she has Alzheimer's and gets very anxious with visits outside of her room?
Right, so if, so the DCPs, by people, okay, so our goal is to reach everyone as a DCP by the end of this week, send out the education, and as long as you complete your education and have a COVID negative test, then as soon as that negative test comes in and you've done your education, you can get into the home and be at the bedside in the room. So I would say if you know you're a DCP and you haven't got your education, it's coming soon, and go and get your COVID test now, because it's good for 14 days. And the education is 1 hour online. If you're not able to do the education online, we do have a book that we can send out to you, or you can pick up at the home. We can make those arrangements. The majority of the pilot DCPs did theirs online. It takes an hour. We do have some support available to help if you run into issues. And we actually have had a volunteer offer someone who has retired from administrative leadership and are interested in helping reunite families, and they're going to help us out with connecting people for the DCP program, answering questions and working through the education process. Since the expansion has gone from about 10% of the residents in each home to everyone.
Great, thanks, Jen. And that does answer another question. I think it was from Pat asking when she might be contacted about being a DCP. So you can expect something by the end of the week, Pat. Okay, next one here. I'm a designated care partner. Why do we need to be tested every 2 weeks when employees at a nursing home, when employees at the nursing, but not the employees, get the option to be tested, and we do not have the option? I'm truly surprised everyone in the nursing home is not tested.
Yeah. So I appreciate the question, and that question was also posed to the ministry. So it is part of the ministry guidelines. We are strongly encouraging all staff to be tested and doing what we can to offer multiple opportunities in the week of testing, so that it isn't just a one time, and if they're not working, they don't have that chance. We're setting up a couple of dates the week of the testing. And we are tracking it. We were a little under 50% on the last dates, but we are working hard to make it as easy as possible for people to be tested. I appreciate the frustration.
Okay, so we went over the different types of visits. Are there a limit per week for visits?
So there is not a limit for the designated care partner. We are just asking that as part of the initial paperwork, you're kind of letting us know what you're thinking, but it's not written in stone, and you know, things can change. There's also in our policy the ability to switch DCPs. So something happens in your life and it's no longer a good idea for you to be a DCP. Either something's changed in your health or, you know, something. And so that can be transferred to another person. We just need to know that that's happening, and we provide them the education. I went off on a tangent, but I think I answered the question.
All right. Dale has a compliment. Dale loves being a DCP and hands-on with mom. Huge appreciation. Thank you to everyone and kudos. So thank you, Dale.
Good, thanks, Dale. And you know, I think it will be helpful for the DCPs that were in the pilot to provide some support to the new DCPs coming in. Of course, masked and physically distanced, but I think it's good. And you know, this might be happening faster than some are comfortable with, not fast enough for others, but it is what we were hoping would happen with the directives. So I feel really fortunate. The teams have worked really hard to get this going, and the family members and the residents have worked really hard. So I think we're in a good place to be able to expand this, where some homes haven't had people in the homes as caregivers. So I think we're ahead of the game in some places.
Great. Okay, are physicians' rounds at the homes back to the pre-COVID levels?
So I'll do a little follow-up on that. I believe that they are. The physicians are coming in and doing their visits with residents. And I believe that their usual things like physicals have started back up. But I'll do a little bit of follow-up on that.
Can a resident be taken out to a restaurant for a meal with family members?
So yes, they can. Again, the nurse is going to ask you, and she's going to document a little note in the chart. This is for everyone that's going on a short-term absence. So yes, you can go to a restaurant. There is going to be education about hand hygiene and masking. And the thing about the restaurants is they also have to follow those rules. So they have their tables distanced apart. They have their staff wearing masks. So yes.
All right, and this participant just wants a little bit of clarity. The caregiver program is the same as the designated care partner program, except for we are now extending it to all patients.
Yes, that is
correct. So how frequently can we bring our loved one home to our home for a short visit?
There is no limit for short visits. There is a policy from the province about overnight absences, and I don't know the details off the top of my head. It's a number of overnights that people are able to go away, leave from the home without having it impact their there's kind of days in the home. But there is no limit to the short-term absences.
Thank you. Tracy is wondering if we will be able to volunteer again soon.
I hope so. So we're gonna get caregivers, DCPs back in the home, and then we'll go from there.
Question here. As a designated care partner, will we have to have a COVID test once every 2 weeks?
Yes, under the guidelines, yes.
And then building off of that, currently staff is not being tested every 2 weeks, correct?
So we offer the testing a number of times every 2 weeks so that every staff member has the opportunity to be tested. We are encouraging them to be tested. We're trying to make it as easy as possible. And, but you're correct, we cannot mandate, cannot force them to be tested.
Okay. Can a doc be tested at the nursing home?
Oh, a designated care partner, I wonder?
Yes. Yes.
Right now, they cannot. It is something that we have, that we've kind of, I've suggested regionally. Is there a way that that could be coordinated? Some of the challenge comes around medical directives. So a COVID test is a medical procedure that the nurse conducting the test needs to be directed by a physician to do so. And so we have the ability, we've figured out the way to do that for our staff and have always been able to do that for our residents, but visitors pose a different level of challenge. So at this point, no. Having said that, we are looking at, there are other options to bring the testing sites like the assessment centers to long-term care homes to make it easier for testing to happen. So that's something we're exploring. No promises, but it is something we're looking at.
That's good. There's a few more questions and comments here. I think some of these specific to the rules and things that you've answered about why staff aren't being tested more frequently, or why, on the other hand, why visitors have to be tested as frequently. And there's a question about staffing levels and things like that. I think these ones are probably better suited to go to the ministry directly through their contact forms, or even to our local member of provincial parliament. If you do have concerns, we have to follow the directives and the rules as they're laid out. We're certainly do appreciate these calls and getting those feedback, because as Jen has said, we've been able to take that and make some positive changes. But certainly if you can, any issues with policy, if you can direct those to the province, I think that's where you're going to get the best responses.
And I'll just add that I take the feedback that I get, I hear it, and I share it where I can and where I feel that it might be heard. So I appreciate, I've been having my COVID test, the nasopharyngeal test, every 2 weeks. And I agree, it's not my favorite way to spend 15 seconds. So alternatives would be better. And so I know there's lots of work happening to find alternative tests to the nasopharyngeal swab. I agree, we are encouraging staff to do the test every 2 weeks. And we're looking at different ways that we can support staff in having the test. And I think other options to the nasopharyngeal swab will help. And we're working on our campaigns for influenza. So it's the same with influenza vaccination. It's best, the more people that have the influenza vaccine, the better. But again, we aren't able to force people to have the influenza vaccine. So I appreciate the frustration, and but also appreciate the feedback, and we'll take that forward.
Thank you. Kathy has a good question here. Does the every 2 weeks of a COVID test start on the date of the test or the date of the negative result?
The date of the test. So you might have the test on the Wednesday, you get the negative result on the Friday or Saturday, but it's 14 days from the Wednesday. I think. I'll see if my phone lights up because I said that wrong. I'm pretty sure that that's how it's a testing to a negative test in the 14 days. So from the day of the test.
That is a good clarity to have for sure.
Yeah.
So we have a question here. Will evening visits be an option soon? Window, inside, or otherwise?
Okay, I'll take that feedback back, that's something. Oh, so my call a friend has texted and said, yes, the COVID test is from the date of the test.
Excellent.
Okay,
so everyone,
sorry,
I was just going to say, so everyone knows, we do have a handful of staff on the call paying attention. So if you want to write some lovely messages to them in the chat window, you can certainly do that there.
I'll take the feedback about evening visits, and I hope that some of you had the opportunity to, in an indoor visit, to hug your loved one at the beginning and or at the end of the visit. And I'd like to share that part of that process was getting in touch with public health and understanding how could we offer this and how could we offer it in the most safe way, and also how do we write that in our screening tool so that people understand what the risk is and that you can hug for 30 seconds. And so when I consulted with our lawyer, he said this was on the top 5 strangest consults that he'd ever done, was language around hugging your loved one. But I'm glad that we were able to get there. And I was hoping that people have had the opportunity to do that hugging, and it was worth the effort to make it happen. And I also know that there's been some children able to attend the visits. And so again, that was feedback from the July meeting, that you were looking for the opportunity for school-age kids to come with an adult and visit their loved one. And so I'm glad we were able to implement that as well.
All right, Jen, I think we have time for 2 more here, and I think we've got through most of them. So the first one that I will do here is just regarding food. So may I bring food into the home for my partner? And another one that I saw in the chat was regarding even just helping eat chocolates or something like that in the room. Is that something that can be done?
I'm trying to remember the details about food. The logical part of me says that if you're going out to Tim Hortons for a short-term absence and you're safely sharing, so I think as a DCP, you can support the resident with food. I'm gonna get clarification. I don't want to make it more confused, although my phone is lighting up. The resident can eat anytime. It's the visitor taking their mask off and eating with them that is the issue and the challenge that we're working to limit. So yes, you can bring food. We are still holding mail and packages for 24 hours, but I'll check with public health to see if that's going to change. But theoretically, we drive through a Tim Hortons or a Dairy Queen. I don't work for them, and I've Dairy Queen at least 3 times. Perhaps I'm projecting now what I'd like to do on a short-term absence. And you don't have to hold that for 24 hours. So resident can eat anytime, visitor, not yet.
All right. I think you need to start eating dinner before we do these calls.
I know.
So the last one I see in the chat here, it kind of ties to the earlier ones. So just to clarify, a power of attorney cannot deny family members to take a loved one if the resident wants to go and can make the decision on their own.
Yes, if the resident is capable. So power of attorney and substitute decision-making is really challenging to speak about in broad terms. So if this isn't answering your question, then I think that you should reach out to me or a member of the leadership team at the home so we can talk about the specifics with the resident. it's one of those topics that it's got lots of nuances, and a resident might be able to have their capacity to make a decision about what they eat, what they choose for their breakfast, but not how to handle their financial affairs, for example. So it isn't just cut and dry. So I think it's better that we talk about it.
All right, Jen. So that takes us to 8 o'clock. So I do just want to thank everyone that did tune in tonight. We're still getting a pretty good attendance for these calls, which is great, and a very engaged group. So we do appreciate the questions coming in. If you have a question, there's a very good chance someone else that's listening also has that same question. So I do like seeing more of those. And Jen, I will send it back over to you to sign off tonight.
Okay, great. Well, thank you so much, Rob, and thanks everyone. Really engaged group, as Rob said. I'm going to clarify physicians' level of care in the home, evening visits, and all things around food and packages. Okay, so those were a couple of areas that I just wasn't very confident in the specifics. So I'm going to clarify that for the information going out. So again, I'll just wrap up by thanking you for being a part of this and sharing your feedback. For the staff who continue on this marathon and are doing an amazing job. And for all of the residents for continuously keeping us full of joy and always seeing the positive side. So thanks very much, everyone. We'll talk soon.